I'm Seth Pollack. I'm the sarcoma program director here, where we treat desmoid tumors. And the DTRF asked me to put together a kind of a mock tumor board. So we'll talk about some cases like we would talk about them at tumor board. Why don't, before we get into any cases, why don't we introduce the team? And when you introduce yourself, maybe talk a little bit about what your role is on the team and where you fit in. So Bob, why don't we start with you? Oh, press the button.
Hello, my name is Bob Alexiev. I'm the Vice Chair and Director of Anatomical Pathology at Northwestern Memorial Hospital and Director of the Bone and Soft Tissue Sarcoma Diagnostic Service. So my job as pathologist is to provide the final diagnosis to our colleagues from the multidisciplinary team. And we can talk later about this maybe?
Yeah, sure, yeah.
Hi, my name is John Hayes, and I'm a radiation oncologist here, medical director of the clinic in Prentice. And my role on the team is in coordination with my colleagues here in medical and surgical oncology, mostly to complement rather than treat primarily with radiation, although not infrequently that is necessary.
Yeah. So my name is Pedro Viveros. I am a medical oncologist, and I work in the sarcoma program and as the professor of medicine here. So my role is usually to see patients in clinic and discuss their care, their management, and lead them through their treatments when you're talking about desmoid tumors.
Hi, I'm Shishra Maithel. I'm the Chief of Surgical Oncology and the Chief Surgical Officer of the Cancer Center here at Northwestern. Again, similar to everyone here, just work in the Multidisciplinary Tumor Board. Again, as surgery is becoming less and less needed in this disease, which is great to see the progress happening, but it's not always zero, so here to offer help when we need to be involved.
All right, great. Well, so I have prepared some patients that I've treated before, and these guys have not seen the cases, so we'll get their takes. So this is the first case. So this is a 55-ish-year-old man who had 6 months of increasing pain, nausea, difficulty eating. I can tell you that he was vomiting. He got multiple opinions from around the city, and this was what his CT scan looked like. Actually, maybe, John, how would you describe the CT scan?
Well, what you see here is 3 different what we call cuts or angles through the patient. And when we're looking at this on the far left, what you're seeing is a cross-section as if the patient is laying with their head away from us and their feet toward us, and they're looking straight up. And in the front 2/3 of that, you'll see a homogeneous mass. And that is just the one image. And it correlates, as you see with the red dotted line here, with that point in the body. Now that's as if they're facing us. And always please remember that we view films and report films as if the patient is facing us. So your left is the patient's right, okay? And then lastly on the right, it gives you a good idea. That's as if we've split the patient down the middle through the nose all the way down through the body. And so you get a good impression of the extent of this mass or tumor or lesion. We use those words interchangeably. And it extends essentially from the upper abdomen all the way down through the pelvis. And as you see in the left-hand window, it's filling most of the cavity of the abdomen, probably also the pelvis as well, although we don't have the full 3-dimensional cuts.
That's great. So he underwent a biopsy, and this is not his tumor. I'm going to show some pathology stuff now. So this is the biopsy. This is not his tumor. This is a desmoid tumor that Bob provided. So Bob, why don't you tell me about kind of what I've got all your slides here. Why don't you tell me about kind of what you're looking at when you get a biopsy sample from these tumors?
This is a resection specimen of a desmoid tumor involving the chest wall, and sometimes this tumor can be really very large and aggressive on clinical and radiologic presentation. In this case, the tumor truly invades the entire chest wall, mimicking a malignancy.
Now, in this case, we got a needle biopsy. So, what are the things that you're thinking about when you get a needle biopsy and you look at it under the microscope?
So the standard approach for diagnosis of desmoid fibromatosis, like for all other soft tissue tumors, the core needle biopsy performed by musculoskeletal radiology. So the tissue is received at pathology, and we usually provide the final diagnosis within 24 to 48 hours. We're calling this turnaround time. Difference in 24 to 48, it depends if we have to use ancillary testing or not. Standard protocol is without routine stain 24 hours, but to rule out other benign or malignant neoplasia, we use some staining like beta-catenin. It's a very characteristic stain for desmoid fibromatosis. Usually it takes 4 hours, but usually with all the cutting and staining of the slides, it takes another day. So within 48 hours, we should be able to provide to the team the final diagnosis. And on rare occasions, as was mentioned in the prior lecture, some of the desmoid fibromatosis have a kind of like unusual or not typical clinical presentation. We can also do molecular studies. Some of the desmoid fibromatosis are associated with mutation with increased risk for recurrence, and we can do this at Northwestern Memorial Hospital. Turnaround time for molecular studies is about 2 weeks.
Let's say you got a needle biopsy and it's a tough call, like you're not sure what it is. What would the other things that you would be thinking about be, and how would you distinguish it and know for sure this is a desmoid tumor?
Yeah, that's a very valid question. So differential diagnosis includes other benign lesions like nodular fasciitis, for instance, but also some malignancy, usually low-grade malignancy like a myofibroblastic sarcoma. To exclude these differential diagnostic entities, we use immunohistochemical stains on tissue sections. Same material, we just do additional staining. And like in this case, beta-catenin stain is a very characteristic finding for desmoid fibromatosis. So the positive nuclear stain would rule out the other two entities. If, again, necessary, we can do other molecular studies or cytogenetic studies.
So when you're talking about the beta-catenin, that's this the one with the brown staining. That's a technique that the pathologists use called immunohistochemistry, where anything that has what they're looking for turns brown. So that is a slide with beta-catenin. The other one is called an H&E stain, and that is a way that the pathologists can really see the structure of the tumor, what it looks like under the microscope.
It's actually antigen antibody reaction, and the brown is just the stain which makes the antibody antigen reaction visible to the pathologist. We can replace it with a different color, like a red color or blue color, but the brown is the most likely. And any antibody can have this color. It's just we have to know which antibody is used to the diagnosis.
And then let's say you did some molecular studies. What would you be looking for here?
So again, there's different molecular abnormalities in desmoid fibromatosis, and this is an example of an in-house case in which performed NGS nucleogenomic sequencing. So in this case, the patient has an S45P mutation. In general, there are 3 main mutations without going too much in specifics. Some of them have an increased risk for recurrence or more aggressive behavior. In this case, luckily for the patient, it was a mutation which was not one of these aggressive variants.
I see Eldad there. Come on up. Why don't you introduce yourself?
Hi. I'm Dr. Eldad El-Nikaveh. I'm an interventional radiologist.
Let me just fill you in. This is the case that we're talking about. Probably not one for cryoablation, but what would you do? Anybody? Sure. What would so I'll tell you, this patient went to another institution and somebody recommended surgery for this patient. What are your thoughts about that?
Yeah, well, so first, I mean, as a surgeon, I need to see all the cuts. So we're seeing static images, so it's very hard, but I'll just talk a little bit more theoretically. Obviously, that's a large mass. So things that we have to think about, one, what is the involvement of the blood vessels that are supplying all of the gut? So anytime you're thinking of intra-abdominal desmoid, one of the biggest things we're thinking about is the superior mesenteric artery, which is the main artery that supplies all of your bowel, and the veins that drain it. So we have to decide whether or not those are spared, how much bowel would you lose if you're doing that. So all of those things need to be considered. Now, prior to the effectiveness of NIRO, which you've heard a lot about in these last 2 days, we didn't have a lot of great options in terms of drugs that would shrink that. But we know that with surgery, recurrence rates are very high, and these are potentially very morbid surgeries. Sometimes you can't get it all out. Again, I can't see all the films there, but with a 50% recurrence rate, we have to be very mindful of what we can actually help with our hands when we're actually operating on patients like this. The other thing we have to think about is with these drugs, is the patient able to eat? Are they completely obstructed? Or do they need a tube in their nose? All these things have to kind of go into factors in terms of how much time do we have, because as you know, based on that study, the drug doesn't work overnight. Symptoms may get better overnight, but radiographically and anatomically, the mechanical obstruction that can happen from these tumors doesn't happen overnight. It takes some months. It can, the average time was about 5 months in that study. So these are all things that we need to factor in. Just on the one cut that Dr. Pollack showed, you can see this is sitting on the front side of the belly, and all the bowel is kind of pushed down. And it's always amazing to me when we see patients with large 30, 40, 50 centimeter sarcomas, how things just kind of move around, and patients are eating and drinking and going around, and this thing is just kind of finding its way. So I didn't see any obvious obstruction there. The stomach was a little bit big, but again, it's hard to say on the, but those are all the things that are kind of going through our mind.
John, would you ever radiate a big desmoid tumor like this?
We run in many of the same limitations that our surgical colleagues do, in that the adjacent tissues can limit how much radiation therapy might be applicable. Especially in the abdomen, there are a number of adjacent organs that are critical. In his case, he's talking about vasculature. The vasculature primarily tolerates radiation therapy much better. However, your kidneys, your liver, and the bowel itself that might be adherent may not tolerate high-dose radiation therapy. And so you have to be very careful. Now, with that caveat, Dr. Meithel also made a great point. Even with radiation in smaller areas where it's considered much safer because we can limit exposure of adjacent organs, the regression tends to be very slow. So symptoms don't go away quickly. I had a resident look at a number of cases, it was probably a decade or more ago. We found that on average for our intact desmoid tumors that were irradiated primarily, it took at least 9 months for there to be a reduction of about half of the size. In some patients, that still led to half of the patients going beyond that without even that much reduction. So radiation can be effective. It's limited in similar ways, a little different in its considerations, but the response as well is similar, and this tends to be very slow.
Dr. Eldad, how big a tumor could you consider cryoablation on?
That was a huge tumor.
That was what? Yeah, that was not a small tumor. Well, I think actually I don't think we have a clear consensus on what the value of cryoablation is in such settings. And it's relevant to the points that we're discussing now, because you could potentially consider a debulking cryoablation here if there was mass effect and that was disruptive, and buy time until the efficacy of other systemic therapy comes in. You don't need to have margins when you're talking about cryoablation. Having said that, we still don't know what the recurrence rate would be and if you would create the sort of increased aggressiveness of a tumor that you sometimes see with surgical resection. So that's my thoughts about cryoablation. I'll say that we don't have a lot of experience, but at this point we have about 10 patients of actually tastes of intra-abdominal tumors. So those can be supplied by parasitized branches of the SMA, and sometimes you'll see that even from parasitized branches of, from the testicular branches from the retroperitoneum. So we could use that as a bridge as well, but you would need to do that angiographically first as a diagnostic study.
And just as a follow-up, so everybody is following, so you mean getting something into the blood vessel to stop feeding the tumor?
Well, actually, so we use the blood vessels as a mechanism to deliver a high dose specifically of doxorubicin.
Okay.
So it's not so much ischemia that you're after, but it's really to drug delivery. And you would need to interrogate the vasculature, find the feeding vessel, do a cone beam CT, make sure you don't have any other vessels.
And did you do that with beads too, or just?
Yeah,
Okay.
only with beads. And the reason is, what's being discussed here is how do you package the drug? Sometimes you can, and historically you can package the drug in kind of an oil emulsification or in between sponge-like material, but the local effect, and by contrast, so you have a 20-fold increase in the local retention of the drug when you use these beads that have more of a molecular attachment than you do if you have more of a kind of emulsification. So you have more systemic drug elsewhere when you give it in other ways.
Okay. Great. Dr. Viveros, what would you do given these other options, TKI or chemo or observation?
That is a great question. So I think going back to how the patient is actually presenting as far as symptoms at this point, to your point, if the patient is able to eat and take things by mouth would be a good thing to know and to help evaluate. Historically, we do things like chemotherapy, and we know patients have, I'd say, responses to different chemotherapy agents. So classically, anthracyclines like doxorubicin, which is exactly what we were talking about when we were talking about the embolization, the interventional procedure we were talking about before, but other historical drugs that are chemotherapy drugs that we can use as well. And with chemotherapy, usually, the time to response could also actually be long too. And we rely on these smaller studies with not necessarily comparing two different groups of patients with similar characteristics. And then since we have the data from chemotherapy, which was something that we would still use, for example, in a patient that cannot take things by mouth, we start looking at the data with the oral medications, right? So if the patient is taking things by mouth, and sometimes, don't be surprised, patients with very large desmoid tumors may still be feeling quite well and be able to eat, and it's interesting, maybe because it's slow growing, maybe because it's not necessarily invading through the bowel or anything. So some of these patients with very large tumor could still be doing fairly well, and they maybe have that time to wait for the effect of the oral medications, and that would be something that is probably, like from our experience, I think in clinic, more sustainable to be done for a longer time too than, let's say, chemotherapy. So tyrosine kinase inhibitors, nirogacestat, they've been tested in many of the patients on those clinical trials with patients with intra-abdominal tumors, and they responded as well as the other patients. So really relying on that. With large intra-abdominal tumors, I'm always concerned with the risk of second things happening, things that could happen too with interventional procedures, so fistulization, so meaning something starts to build into or from the tumor into the bowel or into a blood vessel and cause an infection or bleeding. And with a tyrosine kinase inhibitor, which is sorafenib and pazopanib, we can increase the rates, theoretically, of these things happening. So I would say, with the evidence we have to this date, I would propose we do a gamma secretase inhibitor as my favorite treatment for a patient like this.
Sorry, yeah, I had TKI written here just because.
That's what happened.
Yeah, yeah, but actually, what I mean is oral therapy. So
Yeah,
either sorafenib or nirogacestat. This patient was treated a while ago before we had access to nirogacestat. But actually, this patient was not able to. They were vomiting frequently and they were very nauseous. So I was very nervous about starting them on an oral treatment right away. So the first thing that we did was put him on Doxil. That's liposomal doxorubicin, because it's an IV. That's an IV chemotherapy, and I wouldn't have to worry about him being able to hold the medicine down. So the good thing is you can see for him it was effective, but of course this is real chemotherapy and it has side effects. What side effects might you expect to see for a patient like this?
Yeah, so a few things. So before we start something like Doxil or any other chemotherapy agents, most of these patients will need a catheter because these drugs are toxic to the small blood vessels. So we need a port, which is something that, I mean, could stay in 2025. It's safe and could stay for a long time, but it is an intervention. It's something that we have to do before we start. So these drugs can be toxic to the heart long term. With this formulation, liposomal doxorubicin, the rates are lower, so we are less kind of capped on those and things like that, but it could still happen. So if it's an older patient with already with heart issues or heart risks, this could be something that we would take in consideration. But common side effects with chemo include any gastrointestinal side effects, so nausea, vomiting, diarrhea, so increased risk of infections, problems with the blood count. So a lot of these patients will need transfusions between cycles. They need something to help us kind of boost their immune system, recover their immune system between cycles as well. So it's a very intensive regimen that requires a lot of monitoring. And I think, yeah, but it is, as we will show, it is effective. It's still, in some cases, we would use it.
So after 3 cycles, he was able to, even though he suffered from the toxicity of the chemotherapy, he actually felt much better because he was able to eat, he was able to drink, his pain went down a lot, even though he still was having pain. So just after the 3 cycles, we decided we were going to switch his treatment. Would anybody reconsider any of these different options? Yeah. Sure, would you?
Yeah, so I think prior to, I don't know if you know the answer to this.
Yeah.
What do we know about sequencing therapy of Naro after Doxil? I don't know any data on that whatsoever. Prior to the era of Naro, I think this is someone who I would operate on because that's a large mass. It's going to cause symptoms. It's already causing symptoms. But if you go back one slide, Seth.
Yeah.
If you guys notice the circles, so the white contrast is the stuff that the patient drank, and so the contrast is moving through, which suggests that the stomach is not blocked, the intestines are not blocked. The bowel is able to move the contrast through. It's likely able to move the food through. And the circles are all the same size. So there's not like there's an obstruction here. Again, without looking at all the images, just looking what I see there, I think this would be removable without taking out a significant amount of bowel, creating a short gut situation where a patient couldn't eat or drink and absorb their calories and lose weight. So I think it's removable. And I'd probably, after 3 cycles of Doxil, for maximized toxicity, I would take it out. But now with Naro, I'd be curious if we would sequence things, give Naro and try to, now that we even have more time, even get more response and see if we can get even smaller and smaller, because the goal here of making it, 1, do we need to operate at all, period, or 2, if we have to, minimize the morbidity of the operation. So that's the question back to you, Seth, is can we give Naro after Doxil?
Well, okay, so we actually, so if he was treated today, I would have switched him to Ogsiveo because I think both sorafenib and Ogsiveo are very effective. I think most patients prefer the toxicity profile with Ogsiveo. He went on to go on sorafenib. He's still on sorafenib. He actually doesn't have any problems related to the desmoid tumor anymore. He doesn't have any pain related to it. He does have the side effects of sorafenib, and I've been talking to him at multiple visits now about coming off sorafenib, but he is actually very nervous to come off sorafenib because of what he experienced with the tumor. So I've actually encouraged him because I think that the side effects of sorafenib are bothering him, but I think he's just happy to be where he is, and he's thinking about when he might want to come off. Yes, you have a question?
A couple thoughts. Just eerily similar to my case. So,
oh, is that right?
One is during my surgery, they made the decision to not cut my mesenteric artery despite it being wrapped around my body. There was amazing coordination between the oncologist and the surgical oncologist that made while I was asleep. Second is the sorafenib. I totally understand where he's coming from because it's that fear, right, of not having a cure, and now every scan is what's going to happen. And so there's safety in taking it, but also I agree with your encouragement that getting off is exciting too. And after a few scans of being clear, you start to get a little more comfortable. There's definitely that trepidation every single time. But I guess my question is more of a thought. I love the coordination, but do you ever cut the mesenteric artery, or is that something you guys avoid doing?
So when you say mesenteric artery, if you're referring to the main one, that's a bad idea, but it also depends on at what level you're cutting it. So I don't know, in your case, it may have been at the level which it needed to be cut. It would have sacrificed a significant amount of intestine, which would have left you with a short amount that would then prevent you from being able to absorb your calories. That's what I'm guessing probably was happening in the operating room. And so then they have to make that decision.
I'd actually like to point out just something radiographically. So on the CT imaging that we see that you can, and this is a CT, so we're not looking at an MRI, but you can appreciate almost two concentric circles in that mass, where there's a brighter rim and the inside is darker. And sometimes you can get cystic changes in these tumors or liquefaction of that. And I say it only because, we had a patient recently with a massive mesenteric desmoid, and much of it, especially after treatment, became cystic, and he was very symptomatic from the mass effect. And we did something that we normally don't do. We actually drained it. But we got about 1.5 liters of fluid. Yeah.
Did it come back?
And
Did it recollect?
No, it has not. So, and he was, the relief was, immediate. And, we don't usually think about that. But with something like this, an ultrasound would be interesting. It's certainly an MRI. But it looks like a large significant of the tumor is not a viable mass, but liquid.
Yeah.
That's a very nice response to sorafenib, to be honest. I wouldn't have expected that.
Right. It's very, both sorafenib and Ogsiveo are very effective.
Seth, let me ask you a question.
Yeah, please.
Okay. From the standpoint of the audience here, one of the things that comes up when I'm speaking with patients is the what ifs. So let's say they come off sorafenib. Is there any reason to think it can't be restarted later on? In
That's
other words,
a great question.
is there a reason that I can't have a holiday from the treatment and the side effects and then turn around and restart it? Should there be any evidence of progression? Because we all know that aggressive fibromatosis, desmoid tumors, have a variable course. They may be quiet for a very long period of time, even if we'd have never treated somebody with that picture in the upper right.
Yeah. So I have my opinion, but I happen to know that Dr. Viveiros has data about this exact question.
So I don't think John knows, but yesterday, so before our own data, so yesterday, for the ones that were here, one, let's say retrospective, like a big study was like people got together and tried to get their small number of patients and added up and looking exactly at this, patients that were on sorafenib and that had to discontinue. So it was a university of Connecticut study, and they had even like international collaborators. I think they had like 40-something patients in total that were on sorafenib and eventually discontinued. So they were able to stratify, to summarize what they found, that for patients who responded, meaning they had like good shrinkage and they were on it for at least 6 months, they see most of these patients, as at least in the amount of time they follow up, which was about 1 to 2 years, these patients were still doing well, the majority of them. And in the rare instances where the tumor started to grow back, the cases they presented responded to it, to sorafenib again. So we, from our patients from 2021 to 2024, we kind of looked back. I think we had 46 patients that we saw at Tumor Board. About 22 actually received sorafenib at some point. Of those, one like actually had a quick response that was taken out of the analysis, or not a quick response, a quick progression weeks after. But for the patients that were on it, about 16 at the time that we looked, which is early this year, had discontinued for different reasons. About 1 in 4 had discontinued for side effects. Most of them have discontinued after response and having decided with their doctors. And all but 2 patients in that follow-up period of 1 to 2 years did not progress. So they did not have the tumor grow back. 2 patients had the tumor grow back. Actually, one of them not radiographically, but started to have symptoms again. And the other one had increase in size of the tumor, and they restarted the medication. And in both of these cases, they did okay. And it was back in 2024. So about the time when you're starting to do sorafenib or nirogacestat as well.
Yeah, and I think since then we've done similar with Ogsiveo, because now we're putting most of our patients on Ogsiveo. And I think the patients that I've taken off have also done well. I think one interesting thing that they saw in the study that they presented yesterday was that patients really had to be treated for more than 6 months for you to feel safe taking them off.
And that's actually something that came to my mind, thinking about chemotherapy, because before what we used to do as systemic therapy is usually chemo, and most of these patients stayed on it for like 3-4 months. Most of them didn't go on to 6 months. I don't know if, not that we want to go back to chemotherapy necessarily for most patients, but I wonder if that extra time on therapy is enough to change the tumor or the microenvironment or whatever it is that we don't understand very well, and to a point where we continue to see kind of, sometimes as we see continuing responses after discontinuation, sometimes we continue to see tumor shrink even after the patient stopped these medications. And more importantly, and what we want to get is long-term control, right, without any new symptoms. So I wonder if, time is a factor for all these things, maybe in a similar way or not. So that's something that we don't know.
All right, well, that was a great case. I think we learned a lot from that case. Lynn, I actually don't, I have a bunch of cases, and I think we're probably going to end before I run out of cases. So you just pull me off when we're close to out of time. Yeah, okay. Okay. So this patient was completely asymptomatic, and he had a scan. Actually, at this point, I forget why he had a scan. It didn't turn out to be anything. There was a scare because of something with his prostate, PSA or something like that. Didn't turn out to be anything. But he had a scan, and they found this mass. Shishir, what do you think when you see a scan like this?
I mean, there's something there that shouldn't be there. So the question is, what is it? Given where we are, so it's desmoid, so you're going to want a biopsy. But what I'm looking at, again, just from a surgical standpoint, again, similar to things that I was mentioning before, the bowel does not look blocked. The white contrast is moving through. You can see, and you have a pointer. Do you have a pointer there or no?
Oh, a pointer, yeah.
You can see the little bright white things underneath, at the very underneath, right there. Those are going to be blood vessels that are supplying the intestine. So So those are things that we would look at very carefully in all the different cuts that Dr. Hayes was telling you about before, kind of going through the patient, going through them, this way, going through them this way, looking at to see kind of what it's involving. But this is incidental, asymptomatic. But I will say, this kind of brings up two things. So I moved here in January, and in February, we had a patient show up completely obstructed. She had previously had undergone surgery. So desmoids often occur at places where you've previously done surgery, and that's why the recurrence rates are so high. This patient had an operation about 9 months ago, and at the point where they had attached her bowel, she had basically like a, maybe 15 centimeter size desmoid, but it was completely obstructing her. So came in vomiting and this and that, and there was no way we were able to do any medical therapy because she was in the hospital with a tube. So that patient we took to the operating room the next day, took it out, reconnected her bowel. Sometimes when you have these patients, you have to look at where and to the comment about the mesenteric artery, in terms of the decision of when to treat. So this is a patient who Dr. Pollack's telling us has no symptoms whatsoever. But I think it's important to look at where the tumor is and what structures are threatened, if there were any growth, because as we know, just in simple, a third of them will stay the same, a third of them will shrink, and a third of them will grow. So if this patient were unfortunate enough to be the third that grows, what will it grow into, and what are the consequences and degree of consequences, and what structures would be potentially involved? And I think that potentially helps inform whether or not we start therapy on a patient who has no symptoms. So in this case, again, I don't know how those things are playing, but those are the things that I would be thinking about. I don't think surgery would be an option. Would be the right thing to do here for an asymptomatic incidentally found. The question is whether to start therapy or not, and that would depend on what else is going on in that scan.
So the biopsy was done and it was a desmoid tumor. Yeah. Well, do you have any thoughts about doing an interventional procedure on a tumor like this?
So the irony is that it's when I see a big mesenteric mass that I'm more enthusiastic about interventional radiology, because if it has parasitized blood vessels, they're easier to discover and select and prevent any damage to the bowel. These relatively smaller ones can be more challenging to treat that, and so I don't. That's it. From the radiologic perspective, I'm a little. I'm not sure what's going on along the anterior side. There's some fat planes. I'm not sure if that's bowel or if there's, but yeah. But the short answer there is no. There's no IR. I don't think there's a role for IR here.
What if it was painful?
Even if it was painful, I think my view is you can always make it more painful. Yeah. And I think the role. I think the role for IR in this situation is limited to placing a port. In other words, I think that the risk of intervention. I'll say a few things. So the risk of intervention in the mesentery when you're that deep. If this was on the thigh, all right, then your trajectory until you get to the tumor is you might injure some muscles and you can be forgiven for that. But the trajectory here is through a lot of small vessels that when they bleed, very difficult to stop that bleeding. It's risky to approach that tumor from a direct perspective. And from a vascular perspective also, given the size I haven't had, I don't think you're likely to find a safe place to perform arterial treatment. And so it's really important to know, as I said earlier today, when you don't get involved. And even if it was painful, I would be considering things along the lines of celiac block, addressing the pain, and then, systemic therapy to address the tumor.
Yeah. John, this is a little bit more manageable than the other one. What would be the considerations with radiation in this area?
Well, the tumor itself, based on this cut, is amenable to treatment with radiation therapy. And one of the considerations we will bring is how old is the patient as well. As we were talking, I was thinking that you all should know that this group gets together on a regular basis, and sometimes in a case like this, because this is a dramatic picture, we have to remind each other that the patient was asymptomatic. So first, do no harm, right? So should we do anything at all? Sometimes it takes a group of us to look at the treating doctor and go, no, let's just keep an eye on this. It's the wisest thing to do. But if the patient's symptomatic, that changes the dynamic, of course. And radiation therapy for desmoid tumors has historically been very effective. We control with what we consider moderate doses of radiation therapy. We control 3/4 to 80% of these tumors. Now that may mean stability and very slow regression over months and years, but it's also associated with symptomatic improvement, slow symptomatic improvement. So just based on this cut, and with modern radiation therapy as well, please understand what we do today is light years better than what I was trained to do 30-some years ago, okay? So we can target this lesion, we can exclude the adjacent tissues, and really carry very little risk of treatment if it would be needed. We tend to be secondary to medical therapy now because of its effectiveness, but it is historically something that can work very well.
Great. Pedro, what would you do for this patient?
Yeah, so kind of bringing it outwards a little bit, looking from a perspective of someone that treats a lot of desmoid tumor patients, I'd say if it was any other location in an asymptomatic patient, I'll be all for observation if the patient is asymptomatic. With these intra-abdominal tumors, so we all have, I think, people that treat desmoid tumors, we've all had a few patients where the decision was to observe and eventually something happened intra-abdominally, like the tumor grew quickly, a new kind of communication formed, or the tumor got infected, or an obstruction or something like that. So I'd say this is not true for most patients. I believe that for most patients with desmoid tumors that don't have symptoms, I feel usually very comfortable observing and following up closely and acting if there is consistent progression or if there are new symptoms. But for our patients with intra-abdominal tumors, we tend to discuss with patients the potential risk of observing, because these, especially if they're growing at any rate, it can be something that would be much harder to treat later on than it is right now.
Yeah, we were definitely worried about this patient, and we definitely thought about starting a treatment like starting an oral therapy. We had a long discussion about it. We talked about him at our tumor board. We were very nervous, but eventually, after a long conversation with the patient about kind of what they would want, we decided to do a short time before and repeat the scan. And that's what we did. And actually the tumor shrank on its own. It never required any sort of treatment. This is the scan a year later, and you can see sort of the remnants of where the tumor was over there where the laser is. So these tumors can shrink on their own. It's important to know because your tumor can start to shrink on its own, right? This tumor grew to however big it got at some point. He was fortunate that it was placed in his body just in such a way that it didn't cause him any pain. So it didn't, we didn't find it because he was painful. I'm sure there was a time when it would have caused him pain, but we actually found it on the way down. And your tumor may start to shrink like this at some point. So it's good to know.
Yeah, I can just make one comment. I think this really highlights the importance of the communication and the open discussion between the physician and the patient. It's not, I always say this to my trainees, we're not treating a desmoid tumor, we're treating a patient with a desmoid tumor. It's a very big difference, and always listen to the patient. So I think the patient was right. We would have probably started and the patient was right.
Yeah. Yeah.
So are you finished with this case?
Yes.
Okay, so we're going to just pause for a second.
Yeah.
we're going to take some questions now.
Oh, okay, yeah,
Is
yeah.
that okay? Because we kind of got to wrap at 4:30.
No, you know, I think we've had great discussions, so
Yeah.
that's,
This is fantastic.
yeah.
This is fantastic. I have a question.
yeah, please.
So, I mean, I feel like this is the epitome of everything, right? Is having like all of you guys together, talking, weighing in. I remember being in touch with a patient, this was a while ago, and the patient said, I have a tumor in my abdomen, and I also have a hernia. And I've been seen, my specialist is an expert in desmoid, and I've been in the tumor, the case was seen in the tumor board. That hernia complicated things. How do you guys, as a team, work with potentially other specialists when there are complications with mesh, with hernias, with whatever? How does that conversation, because you guys are experts in the tumor, but when these other comorbidities happen, what happens?
When there's mesh and when there's a hernia, I ask Shisher what.
We ask the surgeon. So again, as a surgical oncologist, we've done our general surgery training too. But to be honest, hernia is its own specialty now. So I'm just one, but there's 150 people in our department, so we just add someone else on. We have like one of the world's experts in hernias and mesh here, actually, who just came the same time I did, so I would call Mike.
I need to talk to you later, because I need that person.
But
Anyway.
again, there's expertise all over. Again, that's one of the privileges of it being at an institution like this, is there's always someone who's seen something before and has expertise in it. But the reality is, in this, 95% of patients don't get treated at institutions like this. That's the issue.
Yeah, thank you. And so we'll open it up.
Thanks. I just had a clarifying question. When Dr. Casper spoke earlier, it seemed that radiation, not interventional radiation, but radiation was kind of the last thing you would look at on the list. And then Dr. Hayes said, you might think about radiation as a way, or do you do radiation after surgery? Can you clarify?
Yeah, John?
Yeah, the role for radiation therapy has definitely moved downward because of the effectiveness of the systemic treatments. And for patients who have desmoid tumors, there are some that have other syndromes, and there's a long-standing worry that radiation therapy can induce additional or secondary malignancies. And that's why briefly, I think when I was talking about that case, I mentioned don't know the age. So especially for younger patients, and then we tend to shy away from radiation therapy. And it's a bit controversial, though. I think that the accepted dogma is, well, radiation can cause secondary cancers. When you look at the studies on patients with desmoid tumors, it's not as consistent as you think. Now, what I mean by that is there is an accepted very low rate of secondary cancer induction no matter who I treat, no matter how I treat, okay? Those numbers, however, are quite small. And they are typically something that is additive over years or decades. So again, the logic is, all right, if somebody is 60 or 65 and 70, we're much more comfortable treating that patient because their years of risk for secondary tumors is still quite low. But you're talking about long-term risk that might be a percentage or two. So it's not like 50% of our patients. I say that as a generalization as well because there are some syndromes and some genetic predispositions that we need to look at or look for that could raise that dramatically. And we would definitely shy away from ever treating those patients. In terms of my compliments to surgery, that's a pun. I'm usually complimentary in terms of subtotal resections. So there are times when it's intended that a full resection be achieved, and that wasn't the case. Again, depending on the scenario, how threatening that residual disease might be or regrowth might be, we sometimes treat after the surgery, and that's called adjuvant therapy. Again, that's really slipped down because of effective medical therapy. Our track record's very good, But I think we have better options today if you're looking at the bigger picture of side effects, effectiveness, and long-term risks.
I think it's a really good, and it's interesting because it's one thing when you're kind of looking at it more like the textbook, like what's the right thing to do, and then it's another thing where we're kind of like on a tumor board format, we're kind of all looking at this and what's the best thing for this patient and kind of trying to keep an open mind. I think that these days, when we treat a patient, probably a majority, I know that most of our patients are going on oral therapy, and for most patients, that's Exivio these days. But I will say that I have referred John a couple patients over the past year because not every patient is a textbook patient. We have some tough patients now and then. Sometimes we have unique situations. Sometimes we have patients who didn't do well with oral therapy or had other various problems. So,
one of the things I'll mention as well is the whole talk could be given to you all about radiation therapy technology today. The complexity of what we do, the customization is so much better. And also we have proton beam therapy. And for certain tumors, proton beam therapy is energy administered to a part of the body just like other forms of radiation therapy. We use radioactive material routinely. That's not what I'm talking about. I'm talking about most patients are getting treatment from big machines that are producing invisible beams of light or energy or particles from the outside. Proton beam therapy can have a real advantage. Younger patients, unresectable disease, because proton beam can limit the depth of penetration of the beam. We can carve things out, create star-like or stellate distributions with the combinations of treatments. So we may have one of our colleagues out at the Proton Center treat the occasional patients where it's unresponsive, surgery might be morbid, and you're trying to protect adjacent organs more so than we can with other modalities. So again, that speaks to, I think, the cooperative and multidisciplinary advantages you have in a center like ours.
Hi, everyone. I have a question in terms of any do's and don'ts in terms of coordinating collaboration across different hospitals or institutions. I think what we've seen is there's a lot of patients who get referred to a hospital, but maybe you still have a main doctor at your old place. Like, any do's and don'ts in terms of driving that, and also how the patient quarterbacks or how other doctors can help quarterback?
Anybody want to take this?
Yeah. So one thing that I noticed that the past 5-10 years, things have gotten a little easier with, at least with the record side of things, which usually takes a while. But now that, most of the information is in the cloud. When you get authorization, it can be pushed and people can actually review things. But it usually takes a lot of extra time, right, to be able to review documents from a different institution and coordinate that. We are used to doing that quite often. I think, and with the testimony of patients here today too, a lot of that, our resources are limited and our time is always limited. So the patients that do well, I think they take a lot of that kind of advocating for themselves and helping kind of being the person coordinating a little bit. It's great when you have, like, let's say in some teams you have very good like nurse navigators or people that are actually specializing in looking at these new patients and coordinating, make sure they have all the information. And from our end, from the medical specialist end, I think like being proactive and contacting our colleagues and talking to them after we got all this information. But that timing is hard sometimes because sometimes you don't have all the information, and that's what kind of it starts to triangulate a little bit. So what would you say?
Yeah, no, I completely agree. And just to simplify the answer, I would say it's all do. There's never a don't, in my opinion. Communication is key, and I don't think you can over-communicate. In the spirits of the previous talk on financial toxicity, patients are coming 2, 3, 4 hours away sometimes to see Dr. Pollack, Dr. Viveros for the specialty, or for what they offer, for what I offer, for what my group offers. but they don't all necessarily need to get all aspects of their care here. So, you know, these guys will, there may be a community medical oncologist 4 hours away. The patient will come up, have a visit, and then they can guide that medical oncologist locally and follow the films. But now with everything being a little bit more centralized, they can keep their care locally under the guidance of the specialists at a major academic institution. And then when it comes to surgery, again, I do this quite frequently in other diseases. They'll get their therapies at other sites and they'll come to us for the surgery and then they'll go back. But again, the financial toxicity can be very, very real, as you heard in the previous talk.
Yeah. Always consider yourself your best advocate. And to steal a line from some friends of mine from college, shy gets you nowhere.
Anybody else? Any last minute questions?
I think this is a self-selected group, so I don't know, you know, if this, you know, how much you need to hear this, but I think that if, you know, if desmoid's rare disease, sarcomas in general rare, and one thing that we, you know, we just wrote a review and kind of looked at some. One thing we know though is that you do get better care when you go to high volume facilities in the setting of sarcoma. So in terms of dues, I think, you know, it's reasonable not to be satisfied with local experience if local experience is limited. It's not to downplay the value of the local healthcare, but there is really value in high volume centers, and absolutely, you know, the communication is key, and you know, making sure that everyone is on board. But when it comes down to quarterbacking, it really is the patients who need to, you know, not be shy and go after the best therapy and the best, you know, the places that have, you know, good volume and good experience. Yeah.